Good day. Cardiomyopathy is always a mysterious issue because of the presence of cardiomyopathy mimics like athlete's heart, infiltrative myocardial disease, and others. Because of the presence of diverse phenotypes like different types of hypertrophic cardiomyopathy, sometimes there is overlapping phenotypes like hypertrophic, dilated, and the restrictive cardiomyopathies can overlap with each other. An issue of familial and non-familial, and the most important thing is that the knowledge is still evolving. If we consider multimodality imaging for cardiomyopathies, echocardiography is the first line investigation, but unfortunately, sometimes this is not conclusive. Cardiac magnetic resonance is a powerful tool, especially for its ability with the late gadolinium enhancement and the ability to perform tissue characterization. But nuclear imaging can have a very important role, especially PET scan, for its ability to detect inflammation and the metabolic derangement. And also, we cannot neglect SPECT and its ability to detect amyloidosis, especially the PYP span. Now, if we consider hypertrophic cardiomyopathy, restrictive cardiomyopathy, and the mimickers, I have considered three entities together because of the significant overlap and confusion in practical life. If the scenario is simple because of the presence of characteristic features of ASH, systolic anterior motion and mitral valve, and the increased LVOT gradient, the issue is not a tough one, and we can reach a conclusion with just simple echocardiography. But unfortunately, there are some mild cases or the earlier cases which can be missed by echocardiography. In that case, cardiac magnetic resonance can play a very important role, and it can pick up subtle cases by its ability to detect late gadolinium enhancement in a characteristic pattern. Sometimes we face apical hypertrophic cardiomyopathy, and if the echo view is a good one, then the game is over. And especially if we take the help of strain rate imaging, in that case, the polar map can detect the area of paleness at the center. And this may be very helpful for the identification of apical variety of hypertrophic cardiomyopathy like here. But if the window is not optimum, sometimes we cannot visualize just the apex. In that case, we can take the help of cardiac magnetic resonance, and it can beautifully demonstrate apical hypertrophy and also the loss of apical LV cavity during systole, as is the case here. So it can contribute a lot. Another important aspect of assessment of hypertrophic cardiomyopathy is to perform risk stratification for sudden death. And echo in many cases may suffice, and it has got at least three important criteria in the form of maximal myocardial thickness, left atrial diameter, and the LVOT gradient, and also probably abnormal GLS. But sometimes we can take the help of CMR because there are increased precision for the assessment of myocardial thickness, and at the same time there are some additional contribution like late gadolinium enhancement, its presence, extension, and progression, and also increased T1 and ECV values. This can be correlated with increased risk of sudden death. We also have to consider the HCM mimickers because all the hypertrophic heart in non-hypertensive subjects do not tell about hypertrophic cardiomyopathy. So just we can go through this case of a 45-year-old lady who presented with anasarca, and the patient had got single vessel disease. This was the ECG of the patient and was treated long as a case of old myocardial infarction. And when we just found the patient, the echo assessment revealed that there was moderate LV systolic and RV systolic dysfunction. GLS was quite reduced to less than 4.7%, and there was grade 3 LV diastolic dysfunction. Look for serum ACE was normal, and there was just in the echocardiography there was beautiful presence of cherry on top appearance. Considering this, we have the thought that this could be a case of cardiac amyloidosis, and we searched for free light chain ratio and the immunofixation electrophoresis of serum, and they came to not suggestive of cardiac amyloidosis. Then accordingly, we took the help of INMAS Dhaka Medical College, and the patient underwent PET scan, which did not suggest cardiac sarcoidosis, but when the PYP imaging was done, this was suggestive of ATTR cardiac amyloidosis. So this was probably the first reported case of ATTR cardiac amyloidosis in Bangladesh. If we consider echocardiography can say something regarding the tissue characteristics. Like if you say here, on the left side, this is called myocardial speckling. It is commonly present in hypertrophic cardiomyopathy, and on the right side, there is granular appearance of the myocardium, which is very characteristic of cardiac amyloidosis, but not specific. Sometimes you can see this in case of chronic renal failure patients. Strain rate imaging in the form of polar mapping can contribute to much. Just on the right side, we have shown you that cherry on top appearance, which is very characteristic of cardiac amyloidosis. And just on the left side, there is athlete's heart, and you are seeing lots of red color indicating that the myocardium is healthy in case of athlete's heart. And you will be happy to know that just the cherry on top pattern is 93% sensitive and fairly specific for the diagnosis of cardiac amyloidosis. Actually, in practical life, this may be the first clue that you are dealing with a case of cardiac amyloidosis, and you should proceed for further sophisticated imaging like MRI and cardiac magnetic and the nuclear cardiac scan. CMR can help in cardiac amyloidosis because there may be diffuse uptake of lead gadolinium enhancement. In contrast to the right side, you are seeing the healthy myocardium. This is the story of a middle-aged lady, 40 years old, who presented with anasarca and unilateral optic atrophy. You are seeing that there was atrial flutter with variable AV conduction. This was the echo of the patient was having biventricular systolic dysfunction along with reduced GLS, and the PASP was 60 millimeter mercury. Just look at the polar map of the patient on the right side. You are not seeing any apical sparing, rather there was a segmental deficit of strain. We did cardiac MRI, and this was suggestive of cardiac sarcoidosis. There was patchy LGE in basal and mid anteroseptum and hypokinesia in the regional pattern. Nuclear imaging, when it was done, PET CT scan at the INMAS Dhaka, this was the reference center, I think, in Bangladesh. And again, the scan was suggestive of cardiac amyloidosis and refuted the diagnosis of cardiac sarcoidosis and refuted the diagnosis of cardiac amyloidosis. So if we just think of that we are dealing with the case of cardiac amyloidosis, we should first do echocardiography with strain imaging, then we should at first exclude AL amyloidosis and then ATTR amyloidosis. And if the thinking is that we are dealing with sarcoidosis, echo is not a very good test, the findings are rather non-specific, we can then proceed for serum ACE, cardiac magnetic resonance, and FDG PET scan, and this can give help in the reaching the diagnosis. You know that the diagnosis is finally based on the application of the different criteria. One renowned one is the Japanese Circulation Society criteria. Echo can be the first-line investigation for the diagnosis as well as the prognostication of dilated cardiomyopathy. If there is any doubt, in that case, cardiac magnetic resonance can help. And also, echo can help differentiation from ischemic cardiomyopathy. But in difficult cases, we can take the help of, again, cardiac magnetic resonance, and it can be a beautiful option. It can detect also the left ventricular non-compaction cardiomyopathy. And in confusing cases, CMR can help a lot. This same is true for the diagnosis of ARVD. Echo can help a lot, but in doubtful cases, we can take the help of cardiac magnetic resonance. And practically, for the assessment of all sorts of cardiomyopathy, cardiac magnetic resonance may be at the center of the diagnostic algorithm. And then, according to the finding of cardiac MRI, we can take up and choose other investigations, including the nuclear cardiology, and ultimately try to reach the diagnosis. With this, I like to conclude. Thank you for patient hearing, and thank you all.
Thank you, sir. Thank you so much.